Okay, so this case is sudden onset diffuse abdominal pain. Patient is older, in their 60s. Anything so far?
The bowel, there's a cluster of thickened bowel loops in the right lower quadrant.
Right.
With mesenteric edema.
Right.
Is it like strings on a balloon sign? And was there hemorrhage in the pelvis too?
No. This was simple free fluid,
okay.
not hyperdense. As far as we know, there was no surgery.
Just trying to decide if I think it's more ischemic or like a closed loop. Can you show the coronal?
Yeah, that's what I was gonna go next. So
is there something in the assembly, like kind of flaw?
nice. Swachanda, what do you think? And I'll put it on narrow windows if that helps.
Yeah, looks like clot maybe in the assembly.
Okay. So definitely, so one of our residents actually picked this up on call. So I thought it was a nice call. There's some wall thickening, minimal perivenular stranding. Mesentery definitely is very congested, and then there is bowel wall thickening. So they called this overnight. So we got a contrast study the next morning. And there it is. So this was sudden acute portal vein and SMV thrombosis. Turned out she was hypercoagulable from one of the coagulopathies. So they did a workup and found that she was hypercoagulable, but this was her first presentation with bowel ischemia and SMV clot.
Did she go to the OR then? Or IR?
No, just IR.
Okay, for thrombectomy. I think this is also an awesome case of, see how quickly there's cavernous transformation?
Yes.
And sometimes people think that that takes a long time to develop, but it's like those vessels already exist in your portal hilum.
Open up very quickly.
Yeah.
Yeah, but I thought it was a very nice
overnight. Yeah, it was a great call.
Yeah. So, and with this surge of non-contrast studies we're seeing now, we need to tune our eyes to subtle findings like this on non-cons.
Yeah, and actually there's nice varices in the gallbladder too, gallbladder wall.
These?
Yeah.
Yeah, they've all opened up, right?
Yeah.
Nice. Okay, I'll stop sharing.
So we just said, since those collaterals open pretty quickly, so how do we know if the clots are acute versus chronic if we don't have prior study?
I mean, I think they're like the same way that we can suggest about DVTs, like if the vein looks expanded, if it looks like they're stranding. Like this clot, for example, looks more acute than like a very, I don't know, withered down vein, calcification.
Right, and it's not eccentric to one side of the vein wall, like it's retractile when it becomes more subacute chronic.
At least in this case, it's not expanding the lumen, right?
It was not expanding, but there was venous wall thickening and a lot of downstream edema. And the presentation.
Yeah, definitely.
Cute.
Yeah, thank you.
Yeah.
Okay. So this is my first case. Oops. Okay. So focus on the uterus. There was this, what we presumed was an intramural fibroid. You can see it's enhancing, it's pretty well circumscribed. The patient underwent UFI, and a year later, they came back. They still had bleeding. And this is what it looked like. It was measuring a little larger and it's still enhancing. So what do you guys think? I'll show you the T2. I'll show you a couple of other sequences. This is the T2.
Aarti, was there any collateral that they did not embolize and this kept growing?
I didn't look deeply at there, but we did talk to the IR folks and they thought that they had fully embolized.
Looks much
Yeah.
more heterogeneous now. And
Yeah. So we were a little concerned about this. We said, like, you know, it looks kind of heterogeneous. It's growing. It's still enhancing. Why didn't the UFI kind of devascularize it? They usually do a pretty good job. And we couldn't exclude a leiomyosarcoma. And it was resected, and this turned out to just be a fibroid with extensive, you know, degeneration and necrosis, even though it was pretty enhancing. So I wanted to just show you guys, we recently had a journal club and we reviewed this paper from the Brigham, differentiating leiomyoma from leiomyosarcoma. And actually they had, Fiona presented this at SAR. And I thought this was pretty cool. So they looked at 15 features of leiomyosarcoma. So, you know, this is a very challenging diagnosis to make. These are very rare compared to fibroids. And fibroids can look ugly, they can be degenerating. And so it's really hard to know when you're gonna bring up a leiomyosarcoma. So they looked at 15 features, and these 7 features were statistically significant for being more indicative of a leiomyosarcoma. So hyperintense T2, finger-like projections, necrosis, hemorrhage, heterogeneity, and an ill-defined border. And they also gave this little algorithm. And basically, if you go down these different paths, you get to what they would say is 100% sensitive for, or specific for a leiomyoma versus a leiomyosarcoma. So I went back to this case and I tried to go down this algorithm. And I would say, I think that it's pretty T2 hyperintense. It's not hypointense like the muscle. And so I said, yes, it's hyperintense. Does it have hemorrhage in it? When you go back to this mass, is anyone else familiar with this paper, by the way? No.
I saw it represented at SAR. I honestly, we've tried to do the same thing, and it's not super straightforward. The two different, she described it, and the paper describes the two different charts are kind of meant to be used separately. And we didn't kind of get to the same conclusion, and it excludes diffusion, which is kind of the scary thing that we see sometimes. So.
Yeah. So well, I'm still confused about it, but I was trying to use this chart. So I thought it was T2 hyperintense, and there was this one tiny focus of hemorrhage. So I don't know how much hemorrhage they want, but if we count that one tiny focus and say yes, then it should have been a leiomyosarcoma, but in this case it wasn't. So I'm thinking maybe the leiomyosarcomas have a lot more hemorrhage than just this. So if we go T2 hyperintense, no hemorrhage, and I don't know what to say about this as far as necrosis, because it looks like these parts are necrotic. So I guess I would say that yes, there is necrosis. And I guess the other thing is the wall, the definition is pretty well defined compared to the myometrium. So I guess in retrospect, that nice definition is also pretty suggestive that it's a fibroid. But I don't know, would you guys have hedged on it, or would you have just felt confident this was a fibroid? At this point,
how many patients did they do this paper on? Like,
it was not a lot of patients, and they're actually now they're now trying to validate it. They're basically trying to come up with a scoring system where you give them points, and then if it's like, you know, then you have a probability, like if you have 7 points, then you have a very high probability of being an LMS, or 1 or 2 points, it's a very low probability. But I don't remember the exact number of patients.
right. Because we've seen very, very large, very ugly looking, you know, like much worse than what this one looks like. And, you know, we've hedged and said can't rule out leiomyosarcoma, and practically every one of them has turned out to be just a leiomyoma.
Yeah, that's been my experience too. So anyway, just so you know, I don't know. I think in retrospect, this nice edge here is suggestive, but I've never seen one that had like this kind of fluid I guess like encapsulated around the fibroid. But I guess they're gonna do a prospective trial using those features, so more to come. This is just a cute case. There was a lesion here. This is the in phase. This is the out of phase. You can see that there's a lot of fat in it. This was a 70-year-old male. Any thoughts? That was our actually poor arterial phase. It looks pretty late, so we can't really assess the arterial enhancement.
It should be an adenoma based on the in and out of phase, but it's not really enhancing as much.
Okay, so yeah, adenomas can have a lot of fat in them. Anything else? 70-year-old male.
Well-diff HCC with fat.
Yes, and that's what this was. So in general, if this was a young female, I would have gone more down the adenoma route. This turned out to be, this was a male. So we said, we really can't exclude an HCC. There are some mild changes of liver disease, and this was biopsied and then ultimately resected and was an HCC. Okay, this case, what do you guys think about? Well, I'll just show you. So there was thickening of the colon here, and there was a little bit of sort of inflammation extending beyond it. So it's pretty thickened. It has all these diverticula. And then there was this like process going beyond it. So we thought this was kind of like a diverticulitis / colitis, like maybe could be in the spectrum of SCAD, which is segmental colitis with associated diverticulosis. And then they also had this renal lesion here. So you can see that it's kind of complex, it's a little hyperdense. This renal lesion on MRI was very dark like this. It was very T1 hyperintense. But you can see that there's a filling defect in it, which you should always be looking out for. And on the subtraction, post-contrast, yeah, we thought there was a little enhancing nodule here. So that filling defect we thought was truly enhancing. So anyway, they ended up resecting both the colon as well as this renal lesion. And the colon turned out to be diverticulosis with diverticulitis. They didn't come down on SCAD. And then the renal lesion turned out to be a grade 2 papillary cancer with extensive cystic change. So I thought this was kind of a cool one. I mean, we can barely see this nodule. We called it a Bosniak 4 lesion, but I was still kind of uncertain, like, is it just going to be like a little area of fibrosis? But turns out this entire thing was a papillary tumor. So whenever you have
can small AMLs not have bled too? Like that nodule is a very small AML that ruptured.
Small AML that ruptured. And you would have brought that up even if we didn't see fat in it. This is what it looked like on
a lipid poor AML. It is so small. But how often do we see papillaries with?
So that's one of the variants that papillary can have, which is like a lot of hemorrhage with like a little papillary frond in it. Yeah, nodule. So that's why you have to always look really carefully at the subtractions. But I have been tricked in that sometimes they'll resect it and it comes back hemorrhagic cyst with fibrosis. So that, to me, I'm still unclear, like when, I kind of bring up both of them sometimes, but I don't usually bring up lipid poor AML.
So if you have a case like this, Aarti, does ultrasound ever help you to tell you it's a hemorrhagic cyst versus a more solid lesion on ultrasound with Doppler that is papillary?
Maybe in David Fetzer's hands with contrast enhanced ultrasound, but in my hands, I mean, I think we often, with like this nodule was so small, like I really doubt we'd have picked it up on MRI.
Right.
Yeah. So, I mean, it's more like we often see but usually when it's like really this homogeneous, I'm leaning towards a hemorrhagic cyst. In this case, we happened to pick up this tiny nodule and, called it Bosniak 4, and this one happened to get resected, and so we had
Nice.
to on it. So
You're lucky that your subtractions help, because
yeah, actually, and that was tricky too, because one of the subtractions we didn't see the nodule, but one of them we felt was like well registered, and we actually saw it. So
nice, great call.
yeah. But it wasn't even just this was the RCC, like this whole thing was the RCC. So that was interesting to me. Okay, and then this is one more, another renal case. This was interesting. So we had this lesion here, and then it seems to be going into the collecting system. And then there's a lot of lymph nodes. And this is what it looked like on coronal. So it almost looked like two different things. Like there was this rounded part, there's this nice part going into the collecting system, and there's an adrenal lesion, and then there's all these lymph nodes. So we were kind of confused. We were like, was this like an RCC? Like the more rounded part looks like an RCC. This part looks almost like a urothelial cancer. And then the fact that there's so many lymph nodes, like should we put lymphoma also in the differential? And are these two things related? And I still am not actually sure, but they ended up biopsying these lymph nodes, and it came back very aggressive RCC. So I believe that these lymph nodes and this are all this aggressive RCC. They even said the growth pattern was basically like infiltrative and going beyond the tubules. And I think this part, I'm still not sure. It actually looks a lot like a hemorrhagic cyst on the T1s, and we weren't sure if it was enhancing, but let's get to, oh, these subs are horrible. So you can see this part, it looks like there's some low level enhancement, but it looks different than this this more aggressive part that's going into the collecting system and the lymph nodes.
Aarti, we have a companion case to this. Can we show?
Yeah.
So this is, so the history on this was a little confusing and complicated. Right side, she had had a congenital UPJO and a pyeloplasty. So that's why that side looks funky with stones and calyceal dilatation and all that. Left side, from what I remember, she had had surgery. You can kind of see the suture line, like a partial nephrectomy. And they were not sure what that was for. But then we have this CT from post-surgery, where we saw kind of these tubular enhancing structures. This is the next phase. And I'll show you coronals. Similar to your case, it looked like it was causing mass effect on the collecting system with some dilatation.
It looks vascular to me.
So exactly.
Like a big AVM or something.
Yeah, so that's kind of what we at first thought too, is she's had some kind of procedure, when they went in there, if something happened and it caused a vascular malformation of some sort. So we were not sure. We gave that as a differential on this CT. Then we did an MR follow-up, and here it is on MR. So I did a CCLS on this. So it's heterogeneous, but somewhat iso to the cortex on T2s, definitely enters toward the collecting system. Then if you compare, this is pre-contrast. So if you do the enhancement ratio, it was definitely hyper intense. So it was 40 to 75% is what you need. This was definitely over 75% on the corticomedullary. And then it dropped a little, not enough to call washout, though it didn't have any fat in it. It didn't have segmental inversion. It did restrict. So based on CCLS scoring, this was actually a CCLS 4. And they took it out, they did a nephrectomy, and did it come back clear cell. So the
No way.
morphology of
No
this
way.
completely fooled us. It was so tubular.
I thought you were gonna say some weird mesenchymal tumor. I guess like this is like Nellie's point, is like clear cell can literally look like anything.
So
And I guess the CCLS worked.
it did. I was going to share screen. Hold on, I'll show you CCLS because, yeah, retrospectively, I was like, we should have applied this even at CT. Maybe, I don't know, it would have helped. So we plugged everything in and see, it gave me a CCLS4. And
Wow, and look at your template.
Yeah.
Beautiful.
it matched the path. So,
Yvonne is gonna be so happy.
but crazy case, but I guess the algorithm helped, and not to be fooled by the tubular morphology and the similar enhancement to blood pool. So interestingly, on the MR, actually, Tarun actually called it correctly. He said, while it resembles the vascular pool, it's more suspicious for a solid enhancing neoplasm.
Yeah,
So-
and that T2 was really not good for
Yeah,
an
the
AVM, right?
T2
Like
was like
there's
that
no
up-
voids.
Yeah, so
Cool. And yeah, so I guess what I learned, so yours is invading the collecting system too, right? Like mine was too.
yes.
Yeah.
That's
so
why I said it's a cousin
yeah.
case to yours. So
Yeah. Awesome. I do have one more.
okay, I'll stop.
Okay. So this patient has undergone some kind of pelvic surgery. And I want you to guess what it is.
Some kind of gender change thing, Aarti.
Yes, good. So this is a male to female transgendered patient who underwent a neovagina creation. So bladder, prostate, and then between the prostate and the rectum, they basically do a penectomy, and then they take the skin of the penis and they invert it into the pelvis. So this rim enhancing fluid filled thing is the neovagina. And actually there was a great talk on transgender imaging at Rankin-Ray. So if anybody is watching those lectures for the rest of the year, I would highly recommend that lecture.
Actually, at RSNA DPS also, they had quite a few DPS with evaluating transgender people.
Cool. What's DPS?
The digital poster session.
Oh, okay. Okay. We haven't had too many of these yet, but apparently they're now starting to be covered by insurance. And so they think the volume is going to go up. Okay, stop share. Okay, does anyone else have cases? At Rankin-Ray, I saw a speaker it was like the last day, Thursday. I think her name was Kavita Patel. She's from a hospital in downtown, like I think it's called Lenox downtown or something. It's a hospital in New York that actually has, I think, the highest number of transgender patients in the country. She also said they now have specialized multidisciplinary transgender centers at Mount Sinai, Hopkins, and University of Chicago. But anyway, she went like from head to toe through all of the different surgeries that transgender patients undergo, like including like frontal sinus surgery to like make your eyebrow bigger to look more male, tracheal shaving, different kind, they don't undergo complete mastectomies because they want like pectoral definition. So they still need to be screened for breast cancer. And then she went through the neophallus and neovagina creation. And yeah, it was
Cool.
excellent. Yeah.
All right. Thanks.
Mm-hmm. And another really interesting thing she said, and then I'll end the session, is that there's this schematic, maybe I can find it. Hold on one sec. So this genderbread person is like, it's a schematic to understand the different terms related to transgendered people. And so she said that biological sex is basically your genitalia, so how you're born, and 1 out of 100 people have non-typical genitalia due to a variety of causes. But that's your biological sex. And then your gender identity is actually based in your limbic system in your brain. So in a way, it's also biological, but it's not related to your external genitalia. It's in your brain. And when you look at the brains of men and people who identify as male, they have a larger part of this limbic system than females or people who identify as female. And this disconnect between the external genitalia and the gender identity that somebody feels inside their brain causes this gender dysphoria. Does that make sense?
Yes, nice words we learned.
I never knew that part, and that like so it is like still biological, but it's not related to like the external stuff. So
Yeah.
I thought that was really interesting. And then there's also gender expression, which is like how you dress and walk and talk, and so that can also be different, right? You could be identifying as a woman but have a more masculine gender expression, etc. Okay, stop sharing. I'm not an expert. I recommend watching that talk.
Thanks, Aarti.
Yeah. Okay. I'll see you guys later.
Aarti. Hey, Aarti,